Now, we go to another very important topic, very practical, and people are very interested in this, and you should be. And it is advanced care planning. Actually, you're more interested in the smaller version of advanced care plan. It's the DNR, DNI, do not resuscitate, do not intubate kind of order. So that's a form of an advanced care directive. So please do not do CPR on me when my heart stops. Please do not put me on a ventilator when I have problems breathing or when I stop breathing. It's done in advance. Your heart hasn't stopped yet. You're not having breathing problems yet. So we don't need intervention yet. You want to say it in advance so that they don't do it. So it's an advanced care request. It's an advanced care directive. Advanced care planning is a way to come up with advanced directives here. Now, all sorts of other care preferences can be put in there. So the question is which ones? Well, they vary. The common denominator is these are the kind of things that we usually do when you have an advanced illness, and these are the kind of things that some people don't want and some people do want, and therefore we want to know which ones you want and which ones you don't want. So this is your way of telling us what you want and what you don't want, because we don't want to do something that you don't want and we want to do something that you don't want, right? So again, advanced care planning is a product of autonomy, right? So right to self-determination. I want to choose. I want to say what I want and what I don't want. I want to be able to tell everyone if I want CPR or not. I want to tell everyone if I want tube feeding or not. So if you look at the various forms, there's so many. You can have tube feeding, dialysis inotropes, CPR, intubation, and antibiotics. Some people even put antibiotics and all sorts of things. So the process of getting all the information, trying to talk to each other, trying to think about your goals, trying to figure out what is in line with your goals in life or what's in line with your values. Or meeting with a family, you get to tell your wife what you want and what you don't want. They kind of argue with you, and then they come up with a final decision. The doctor's there to kind of help you out because some of the details are technical. So that's the process of advanced care planning. And the thing about advanced care directives and all those forms is, in some countries, they have legal weight, and in some countries, they don't. So if you go to the countries of North America, like Canada, US, and a lot of countries in Europe, if somebody comes in, you have to go in there and remind them that they have the right to fill up their advanced directive. And you have to assist them in every way so that they can do it well. Why? Because you want to give them the right to decide for themselves. So now if they do complete the form and they put stuff in there and things really happen, then the institution and the doctors have to try their best to follow whatever's on the form. Why? Because there's a law saying that they should. In some countries, like ours, in the Philippines, we don't have that law. It doesn't really matter whether you remind them or not that you have an advanced directive form and they can complete the form. And it doesn't really matter if there's something in the chart that's signed by the patient, but the surrogate or the legally designated surrogate decision maker wants otherwise, then you follow the surrogate decision maker if the patient's already comatose. So it doesn't matter what's written in there. Why? Because that form on the chart, regardless of whether it's signed by the patient or not, or notarized or not, doesn't have a lot of legal weight in a country without any law about it. Now, also be careful about advanced directives. Some people just put the form inside the chart. Okay, this is the advanced directive. We put it in the chart, and that's pretty much it. Since there's no law, that's an informative form without a lot of legal weight. That's not an order sheet. You put it in there to tell everyone what the patient wants or what was accomplished, and then you talk to the surrogate decision maker if the patient's already incompetent, and then you write an order. And the hospital or people will follow your order and not what's on the form. Now, of course, the patient, while he was still awake before he became competent, the patient was praying or hoping that you would follow whatever he wrote inside the form. Okay, so a simple guide, practical stuff. So you're deciding on certain things. Do you want tube feeding, inotrope, CPR? This is a lot of decisions, itemized decisions. And therefore, for you to decide, you need all the information that you need to decide. And then it would be a good idea if you have your goals worked out. Okay, if there's new information like suddenly you're incurable, okay, that's new information. Maybe your previous goals, which is I want to get better, it's not going to work anymore. So then you have to rework your goals. So you have to have gone through disclosure, clarification of information, and goal setting before you do the advanced care planning, which is a form of decision making. This is the third communication protocol: withholding or withdrawing medical procedures. So don't do advanced care planning if you haven't disclosed enough information, if information is unclear, and if the patient's confused and the family's confused about goals, right? So as a reminder, you have to explain what it is. There's still a lot of people who don't understand what it is. So imagine if you present this form to someone who doesn't understand what it is. Okay, they're lying down in bed, and they're sick and they're worried and suddenly they're scared, they're lying down in bed and all sorts of things are being done to them and they have a feeling that it's not getting any better. Okay, nobody has disclosed stuff to them yet, or they did, but it hasn't sunk in yet. And suddenly the doctor comes in with an advanced directive form and you look at the form and it asks, when your heart stops, do you want us to do this? When you stop breathing, do you want us to do this? And so what will you think? You get scared, right? So maybe I'm really going to die soon, really soon, maybe tonight, maybe this afternoon, right? So this form feels threatening, feels scary, and it shouldn't be. I mean, how can you think well if you're scared or threatened? And that's not what it should be doing. What it should be doing is giving the patient the right to tell everyone what he wants or what she wants. I mean, the patient should be happy that he's given the right or a chance to tell everyone what he wants or what she wants. So my suggestion is, in so many words, say something like this. If something really bad happens, and we do know that your situation is not that good, and we're still hoping, like you, we're still hoping for the best, but we want to be prepared. We want to know what you want and what you don't want, because we want to do the stuff that you want, and we don't want to do the stuff that you don't want. And that's the reason for the advanced care planning, and that's the reason for the advanced directive form. And that becomes, that's empowering. That's actually giving control to the patient. So instead of feeling worried or scared, of course, he would probably feel worried or scared. Like, if you look at the question, if your heart stops, I mean, even with that explanation, you feel worried or scared. But hopefully, it's a lot less with that kind of explanation. So you feel empowered. Oh, that's good. Actually, advanced directives are even given to people who are not lying very sick in the hospital. Geriatricians advise their patients who are very healthy in their late 60s or 70s that they have the right to fill up an advanced directive just in case. I mean, who knows? Okay, so if you feel strongly about CPR and not getting intubated, or you want a ventilator, you want to make sure that people do that. You don't want to assume that you don't want it, and there are certain things about dialysis that you do want, or tube feeding that you do want and you don't want. Then this is your chance to put it down on paper, because you might not have any chance to do it when it happens, right? A sudden stroke and then suddenly you're comatose. So no chance to tell everyone what you want, right? So this is the documentation. So we actually even make people do this, even if they look somewhat healthy, okay? Even if they don't look very terminal to us, right? So now, also note that this is very, very difficult. I mean, if you look at questions, when your heart stops, do you want us to do this? Obviously, if we don't do this, you die. If you don't put you on a ventilator and you stop breathing, you die. So these are very, very sensitive matters, and a lot of people need time to think about it, need to think about things. Now, if you put the family members into the mix, then they really do need a lot of time. The patient doesn't want to be resuscitated anymore, and then the wife hears about it, and then she starts crying, and the kid also says, no, you shouldn't be doing that, and then they argue. So this is a very difficult thing, so you have to give them time. The wife might not agree with the patient, how come you don't want to be revived? And the kid starts crying. She feels really sad. She feels that's wrong, and so they need to figure things out. So the point is to give them time, to help them if they need help, right? Most of the time they do need help, because they might have technical questions. I mean, even if they might have other questions that they need answered, that they just thought about now. And then you help them accomplish the form. Some people don't know what an inotrope is. Hopefully people know what a dialysis machine is, but then they might have questions about the kidney function and also. So sit down there. When they have questions, answer the questions, and they'll talk about it. And when they're ready, sit down there to help them fill up the form. And then once you accomplish the form, make the form work. I mean, it's useless if you just put it on the chart and the chart goes to the record section and then people forget all about it, and then that's a waste of a lot of effort, right? So make several copies of the form, give the family a lot of copies, maybe 2 or 3. Keep copies for yourself, because if the family finds themselves in an institution and they lose their copy, they're so distressed to start, and they prefer not to answer the same questions again. They can easily tell the institution or that hospital to call you up, or to call your clinic, and then you can tell them you can send them a copy of the form. So keep copies of the form, and some people even give copies of the form to the nearest hospital. So if something happens and that's the hospital they usually run to, then it would be a good idea if that hospital's emergency department or that hospital has a copy of that advanced directive form, right? So if they're visiting us in the capital region, but then they go back to the province, and if a sudden stroke happens, I mean, they're not going to drive 8 hours hospital. They're going to go to the usual nearest hospital or the urgent care facility that they usually go to. and therefore it would be a good idea if this urgent care facility have their form. Okay. Now, the law says that if the patient cannot decide anymore or becomes legally incompetent, or the patient loses decision-making capacity, then somebody else has to decide for him, obviously. And so, of course, the question is who? Should it be the hospital? Should it be the doctor? Should it be the wife or the children? Who's the surrogate decision maker? In most cases, the surrogate decision maker would be the closest next of kin. The formula is usually wife, and then kids, the competent kids, the legally competent kids, not the younger ones, and then the parents, and then the siblings. That's the usual formula. Now, of course, this is not universal. So if you find yourself in another country, make sure you know. Of course, you have to make sure that you're asking the right person. You might not be asking the right person, which makes everything legally invalid. So you're doing something without consent. So you don't want to do that. Now, the question is, how should the surrogate decide? Again, it's autonomy. So autonomy means you want to do what the patient wants, except that the patient cannot decide, think, and tell you anymore because he's incompetent or he's comatose. So what happens now? Well, you look for a way for the patient to still tell you what he wants. So how do you do that? Well, maybe the person who knows him the most will be able to decide for him because he or she knows the way he thinks, his values. The patient might have told this person his preferences, or maybe even if he hasn't, or even if he hasn't told him or her his preferences, this person can probably guess what those preferences are because he or she knows him the most. So who would that be? The person closest to him, right? So, and that's the reason for the wife first, and then the kids first, because we're thinking the adult kids are probably closer to the patient compared to the siblings or the parents, the kids, and then parents and so what's the practical application? If you're asking the wife who is the next of kin, the legally designated surrogate decision maker, and then the wife asks, why are you asking me? I don't know how to decide. And then in so many words, you tell the wife, the reason why we're asking you is because you're the one who knows your spouse the most. Can you tell us what he would have said if we asked him what he wants? Okay, so can you tell us that? What he wants? Can you speak for him? Because you're the one closest to him, right? So that's the idea of substituted judgment. Now, there's another principle that's sometimes used, and the question is, what do you think is the decision that's best for him? So if you're asking the spouse, decide based on what you think is best for your spouse. So that's the best interest standard. In some countries, they follow the best interest standard. In some countries, they follow the idea of substituted judgment, or deciding based on how well you know the patient, what the patient wants. And sometimes they pay attention to both. In most cases, if we stick with the autonomy principle, the right to self-determination, the first one would be more weighty. Meaning, if there's a big ethical legal discussion, or even if there's a court case, especially in Western countries or in a lot of countries who follow Western ethics and Western law, the one who can convince everyone that what they're saying is what the patient wants wins. Okay, so now if you, like for example, you have the parents and then the husband says, no, she doesn't want that, and the parent says, no, she wants that, or keep on going, don't take off the ventilator. The one who can prove to the court that they're representing the patient, like the patient really wants it or doesn't want it, wins. Substitute the judgment. Again, what this highlights also is you have to know the underlying reason. You have to know how they're deciding. How they're deciding is important. Meaning, they have to be deciding based on how well they know the patient, and or based on what they think is good for the patient. There shouldn't be any bad or conflicting self-interests going into the mix. There shouldn't be any problematic self-interests going into the mix. For example, don't do this because I'm sick and tired of going here taking care of this person. That's not a good reason. Okay? That's not for the patient's good, and this is what he wants. Or please don't revive our grandma anymore because we want to get the inheritance, because we want to enjoy our lives. That's not there. I mean, that's not for the good of the grandma, and that's probably not what the grandma wants. Maybe she does, but no, probably not, right? So there has to be a good reason. Now the question is, what if you suspect that? Then it goes to the hospitals legal office, and then you have to bring it to court, and then the court prevents the surrogate decision maker for, and the court prevents the decision and tries to look for another surrogate decision maker who can decide for the patient. So it's a complicated process. It's hard to do in poor countries or developing countries, and so it's not a perfect scenario. So you can almost guess that situations like that do happen, or interests come into the mix, and sometimes the doctors don't pick it up also, and even if they do, they don't want to go into the hassle of going to court and going to the legal office and things like that. But my suggestion is that's the proper thing to do. If you suspect something wrong and the decision is so unusual, and the surrogate actually gave the reason for the decision, and it's not one of the two, it's questionable, you have to protect the patient, right? So you have to try to protect the patient. Happens. There are certain things that are very obvious. It's obvious, therefore it's not in the reference. But I have to point it out because it does happen, and you're actually going to be taking care of patients, and just to point it out, or if you do it, at least you know that it's not the right thing to do. Certain obvious things. For example, surrogate decision makers are decision makers who take over when the patient is already incompetent. So if you're rounding and the wife is there and the patient's intubated but awake, able to understand what you're saying, just because it's so hard to talk to an intubated person, don't face the wife and talk to the wife and ask the wife whether the patient should have CPR or not, while the patient is wide-eyed looking at you and wondering why you're asking his spouse and not him, right? So ask the surrogate only if the patient is incompetent. Okay. So next one, not all family members or not all family caregivers are surrogates. And sometimes in a very busy hospital, we just ask whoever's there, who are you? Oh, I'm a family member. Or, oh, okay, let's talk about CPR. But that's just the sibling. You have to go through the wife, the kids, and the parents first. Just because they're in the province doesn't mean they're disqualified, because it's so hard to go to the phone and call them up. No, you don't do that, right? So you only go for the next one if you really tried your best and you cannot get to designate the next of kin. But you have to document it well. Even worse, what if the cousin is the one at the bedside? You don't ask the cousin. What happens if you do that? That's a legally invalid decision. That's a legally invalid order. Now, be careful about wives, okay? So our partners, be careful about wives or partners. Countries would have different laws about partners, wives, legal spouses. Okay? So people can be married. Some countries don't have divorce. So even if they've separated, they're still legally married. Even if this person is living with someone else because he's separated with his or her spouse for the past 10 years, since they're not divorced, that's pretty much still the legal spouse. So now if the patient's not married and they're living together, that's common law, right? In some countries, they have common law, okay, and they have laws about it. Unfortunately, for example, in the Philippines, these laws do not cover medical decision making. Okay, so be careful with those. My best advice is it's still better to try to get a consensus to talk to each and every one, even if you're face to face with the legally designated surrogate decision maker. It's still a good idea to get the kids or the parents involved so that everyone's on the same page. And it's better to do that. It's better for the family so that there won't be any conflict. Everyone understands each other, and so it's better to do it that way. You don't want people blaming the wife or the spouse or the husband for refusing CPR. You don't want people blaming the family member because he or she signed the DNR. Okay. Now you always have to document things well. Don't just write, don't do this, and then without any accompanying order. At least you have to clearly say you talk to the family and this and they understood fully. You talk to the family, they understood fully, and they asked about this, and you explained things to them well, and this is what they wanted. Actually, since this is a very, very sensitive decision, it's better if these comes in standardized forms so that you don't miss all the details. Okay, so remember, this is a decision to withhold something that would probably lead to death. So it has to be well documented and explained. Okay, so we have patient-assisted suicide in euthanasia. So it is very interesting, very controversial, and people usually ask about these things. So when there are workshops and there's Q&A, guaranteed there's going to be a lot of people asking about euthanasia and physician-assisted suicide. So more euthanasia because some people don't know what physician-assisted suicide is. Some people call physician-assisted suicide euthanasia also. So what's the difference according to your reading material? If you provide the information, you advise the patient, this is what you do, and then you set things up, but the patient does it to himself, then you just assisted. So if you explain to the patient, you talked about it, and then you set things up and you were the one who did it, like you put in the IV tubing, the patient of course knows what you're doing, and then you injected a big amount of potassium chloride, then that's euthanasia. Or you put in the big dose of sedative, then that's euthanasia. Okay, so in common language, both are called euthanasia. So you advised, you told the patient what to do, and therefore the patient did exactly what you told him he can do. That's one. Or you did it yourself with the patient's consent. They fall usually in the same category. You're very active. Okay, so you were a very active participant. Okay, so what I can tell you about this is it's a worldwide debate. You can have some countries who actually made this legal. So you have countries and societies who think this is okay as long as they put in restrictions and rules and they can watch it closely. And there are a lot more countries who think it's not okay and it shouldn't be done. Of course, the debate is very complex and complicated, but if we just apply the 4 principles, well, we can sort of guess. Those who are in favor of euthanasia would say, well, it's self-determination, the right to decide how you die, right? So you're suffering, you're in severe pain, the doctors have been doing all sorts of things already, and they cannot seem to get the discomfort and the distress and the suffering out. They cannot seem to control the discomfort and suffering. They've done everything that they can, and therefore you say, and you decide, then maybe you should help me die. And so the society has a law, and then it says, okay, we believe you, and you go through the very strict procedures and get euthanasia done. I mean, it's very strict. I mean, in places where there are laws, they have very strict protocols. You don't just say, okay, you go home and you pull out the tube, you die, and that's no. I mean, that's different. Nobody does that. In countries where they legalized it, they made sure things are done well, or patient doesn't suffer during the entire ordeal of performing euthanasia. That's why they're using sedatives, because the sedatives put you to sleep and then kills you, right? So Dr. Jack Kevorkian, the pioneer, is potassium chloride. And of course, that would give you a cardiac arrest. And then you ask, what about the other side? Okay, so those against it, well, obviously, it's something along the lines of you're harming someone, you're killing someone. So in a lot of people's minds, if you do something to kill someone, that's the ultimate harm. You're ending someone's life. Again, so non-maleficence, it's wrong. You're harming someone. Very much related to that is sanctity of life. Sanctity of life, it's wrong. You're harming someone, and you're ending life, and life is sacred. Okay, so if you want a non-religious version of sanctity of life, life is very precious, is very valuable, and therefore you shouldn't be ending it. Even if the patient wants you to end it, you shouldn't be doing that. So that's the religious and the non-religious version of the sanctity of life. Of course, the non-religious version is kind of weird, and you can guess who came up with it. The secular medical community, the Westerners. Okay, so that's the non-religious version. These are the same kinds of argument you've heard when they were debating about the death penalty, even the therapeutic abortion. Obviously, in the Philippines, newspaper, unless you want your face in the front page of the newspapers and talked about all over town, unless you want to be incarcerated, or then you don't do euthanasia because it's illegal. There's no law legalizing euthanasia in the Philippines. So be aware if your country has laws about euthanasia, and not just whether it's legal or not. What does the law say? What are the procedures? Okay, so if you want to do euthanasia, what's the policy, the procedures, the rules of doing so? For euthanasia, there's another question. What if the patient's really suffering and you've done everything that you can and there's nothing left for you to do? You've used all the medications that you can possibly think of. You've gone through all the journals of hospice care. There's nothing left, and the patient's still miserable, and the patient's still suffering. Okay, one answer is palliative sedation. You sedate the patient up to the point that he stops suffering. The usual protocol is to get you sedated if you're the patient who's suffering, up to the point that you're pretty much out of it, but you can still breathe. Almost euthanasia, but not yet. Okay, so that's palliative sedation. So you're out of it. And then they'll keep you that way until you die. So they can only do this for people who are really terminal. or near death. And then, of course, the question is, do you feed that person? I mean, if you sedate the person and don't feed him, then he'll obviously die. It varies depending on what country you're in, and of course, there's decision making with the family, and so you have to be. If you're going to do that, it's still very tricky, not as controversial as euthanasia or physician-assisted suicide, but you have to be aware of the parameters and the rules and the procedures in your place or in your country as far as palliative sedation procedures are concerned.